Hello, everybody. Welcome to this webinar on global mental health, reflections in anthropological practice. This is a webinar of the Brain and Mind Institute at Aga Khan University. I am Diana MacKay, the global practice lead with the Institute, and I will just remind you of a few things that we would like to have in your mind as we get started. First of all, you'll probably notice already that we are recording the webinar and it will be posted on our Institute's website in due course. We will post the link for that Institute in the chat, and we would really encourage you to take a look at the Brain and Mind Institute, either during the course of the webinar or in the days following. We're very proud of the work that we're undertaking at this new Institute, and we'd like you to know more about us. There will be a poll that we'll be conducting during the course of this webinar today, and it's using a software called Menti. The intention is to get some feedback from you on the extent to which you are already familiar with the discussions and the topics that we'll be talking about today, anthropology as it relates to mental health. And so I would invite you now to participate in the first question in the poll, which you can see now on your screen, and you can access this through the link in the chat. And we'll just do a bit of a baseline question here about to what extent do you already know about anthropology and its practice. So I'd like to invite everybody to engage in that poll activity that will continue through the course of the webinar, particularly as we get into the Q&A section towards the end of the webinar. Just one or two other words. I'd like to encourage attendees to make use of the chat function in Zoom, which we've fully enabled so that you can introduce yourselves and tell us where you're from in the chat. Please go ahead and do that. You can share some comments. You are able to chat either with the panelists or with everybody. And so I'd encourage you to use that little pull down menu in the chat there to determine whether you want to send your comments just to the panelists or hopefully to everybody, including all participants and all attendees, so that everybody can benefit from your thoughts. And we will be sharing some additional resources with you in the chat over the course of the webinar. We have also enabled the Q&A function, so you can pose questions that you'd like our moderator and speakers to address. And we would encourage you to put your question in that Q&A function as opposed to in the chat, so that we can easily curate those questions for the section of the webinar today on questions and answers. And finally, I'll just mention that we always encourage you to communicate with us also by email, and we'll be posting some contact information in the chat. Now, to get us started, I'd like to hand over to the founding director of Aga Khan University's Brain and Mind Institute, Dr. Zul Merali. So Zul, over to you.
Thank you, Diana. Good morning, good afternoon, good evening, based on wherever you are. People are joining us from many different places, so welcome. Today, I'm very happy to see you all participate in this exciting webinar where you will get to learn about anthropology and how it relates to mental ill health, all the questions that you may have but were afraid to ask. So you'll have a good expose of how the interface works between the domains. As Diana mentioned, I'm Zul Merali, the founding director of the Brain and Mind Institute, which is really a young institute recently minted at the Aga Khan University. And it's a global entity in the sense that it has, it'll work through hub and spoke model. And so we have a hub in Nairobi, Kenya that'll serve East Africa. And then we have a hub in Karachi that'll serve Karachi, Pakistan, that'll serve South and East Asia. So with this institute, I think that you can learn a lot about us through our website. So I won't take too much time about it, but I'd rather focus on a couple of recent developments that I'll talk to you about. One is that we recently developed an integrated framework, integrated mental health framework. And what this is going to do is to turn our approach to mental health a little bit on its head, in the sense that we won't only create focus on people who are severely ill, but also begin to address the needs of people who are at risk, people who are mildly ill, moderately ill, and how do we mobilize treatments on the ground using probably different types of care providers to meet the needs that are so huge in the developing countries where we're at, because in those geographies, we'll never have enough psychiatrists and social and psychologists to meet the needs. So this integrated framework provides a step care model that is being launched initially by the World Health Organization. The second thing is that this framework will also help serve as a lightning rod to attract and mobilize the energies of so many talented people all across AKU globally. And so that's about the framework. And also you can learn more about that in the website as well. And then the last thing I wanted to mention was that one of the major initiatives that the Brain and Mind Institute is launching is the creation of an implementation science team, because I think it's imperative for the Institute to mobilize research to actually meet the needs of communities that we serve. And how can we do that? And so the implementation science team is focused on that. And it constitutes of many different kinds of experts. So we have, for example, data scientists, psychologists, psychiatrists, we have anthropologists, we have economists, and so on and so forth, epidemiologists. And the reason we're creating such a 360 view as a holistic approach to mental ill health, and how can we make an impact that's really impactful and important to change and to address the needs of the communities that are very much in need. So in that context, the webinar that we're hosting today deals with the interface between anthropology and mental health. Why is that important? Why are we investing in it? And why do we, what do we plan to glean from that interface to actually make the difference that we need to? We are very sensitive at the Brain and Mind Institute of the communities and geographies that we serve, because there's quite a diversity of communities. And you cannot just pick and choose and pluck in treatment interventions just like that. You need to be very cognizant about whether it's going to be taken up, whether the communities are ready, whether they want to take on those types of interventions. How can we tweak them so that they are more accessible to the communities that we want to serve? And so without delving further into it, anthropology plays a very important role in research and care interface in terms of how do we implement new modalities of treatment and research for the communities that we serve. So with that, I'm going to stop and pass it back to Diana. Thank you.
And in turn, Zul, I will turn to our moderator for the webinar today, Edna Bosire, our wonderful colleague at the Brain and Mind Institute and a medical anthropologist of her own ranking. Edna, over to you.
Thank you very much, Diana, and thank you very much, Zul, for the introductory remarks. Are very interesting, and I take this opportunity to thank all the audience for joining, and also our panelists for joining. I really look forward for a very, very interesting conversation. I can see some questions already in the Q&A section. Please carry on, continue posting your questions, and we will come to those questions later. So at this point, I would like to welcome our panelists. We are being joined by Mr. Aneel Brar. Aneel is a research fellow at BMI Institute at Aga Khan University, and is joining us from the UK. We are also joined by Dr. Andy Kim. Dr. Andy is a medical anthropologist and is affiliated with Center for Global Health at the Massachusetts General Hospital in the United States, but is joining us from South Africa. We are joined by Dr. Amuyunzu-Nyamongo. Is a medical anthropologist as well as a social anthropologist. Is the founder of Africa Institute for Health and is joining us from Kenya. I am a medical anthropologist, as I was introduced earlier, with the Brain and Mind Institute, and also a postdoc at the Georgetown University in the US, and I'm joining you now from Malawi. So you can see we are diversified from across different parts of the country, and we are here to just try to illustrate or give you examples on how we contribute to the field of global health or even psychiatry. So without further ado, I remember in our poll, we asked whether people are familiar with anthropology. And what I could observe from the poll is that many people are not really very conversant with the field of anthropology. And I would like to take this opportunity to welcome our panelists, and maybe they can tell us what anthropology is. Maybe I'll start with you, Andy. What does anthropology mean to you?
Yeah, thanks so much for having me. As Edna mentioned, my background is both in biological and medical anthropology. My primary training is in biological anthropology, and for the type of work that I do, most of our research is focused on understanding the trends and variations in human biology and health inequalities. Specifically, the type of research that I focus on are on the intergenerational life course mechanisms of stress transmission from the context of South African apartheid. I think about this from a variety of different perspectives, but the main sort of focus that I take is called the biocultural approach, which integrates different perspectives like political economic views, social cultural systems, and integrating those to understand how human health and biology manifest across different contexts. And what's really great about anthropology for me is that we're able to take different forms of inquiry and modalities to understand a particular concept. So something like mental health is obviously so intertwined with the social and cultural context, very much intertwined with political economic realities, but also very much a product and involved with psychological and biological systems. In order to have a holistic understanding, and especially a culturally relevant understanding of these very important concepts, anthropology really provides us a broad array of perspectives, but also a lot of depth in order to understand these in real time. So I'm happy to speak more about my work later in the call, but those are some of my perspectives on anthropology and where I'm coming from.
Thank you very much, Dr. Andy. That is perfect. And Dr. Amuyunzu, welcome. Would you please tell us what you understand anthropology to be and in relation to mental health? Thank you. Over to you.
Thank you so much, Edna, for inviting me to come and speak about anthropology. It's interesting that many years down the line, even in Kenya, people still don't understand anthropology. I was in the first University of Nairobi class of 1986 when we were introduced to anthropology, and we have many students who have passed through the university and other universities in Kenya to study anthropology. So this is a good opportunity for us to explain a little bit more to different people what we understand as anthropology. In my view, anthropology is a study of what makes us human, what defines us. Anthropology helps us look at the different aspects of being human: economic, social, health, and political. So basically, what I've found over time is, as an anthropologist, you can fit anywhere. I look at various aspects of anthropology. I study gender. I've done work on HIV and AIDS, poverty, currently working with a consultant for the World Bank, working on social issues, basically in applied anthropology. So in terms of our understanding, if you just summarize it, like what makes you human, really captures what anthropology is. And in terms of mental health, what has been of interest to me is, how does society look at mental illness? How does society define mental illness? And what care patterns can we get that are traditional, that are modern, and how are those interpreted at the personal level? So as we go on with this conversation, I'm hoping we'll be able to explain what role we play, not we can play, we currently play in mental health, in the mental health space, in the non-communicable diseases space, in the communicable diseases space. So every space where we are looking at human beings, anthropology is relevant. Back to you, Edna. Thank you.
Thank you very much, Dr. Nyamongo. Aneel, would you like to add on to that?
Sure. So I think for me, anthropology has been important as a way to understand the problems that I deal with in the field. So just to give a little bit of context for people who might not have read the bio, where I come from is implementation work. So I work in Rajasthan, and I started off working to design programs delivering mental or maternal health care to vulnerable women in this rural area. And my kind of foray into anthropology was due to a dissatisfaction with the knowledge that I had going into the field, which was basically national level kind of public health epidemiological knowledge and that way of understanding health inequality. And, you know, after doing that, trying to design programs based on that knowledge for several years, I was dissatisfied and wanted to find a new way of looking at things. And that's where the anthropology
Aneel,
said, yeah, can you hear me?
we were cutting out a little.
Oh, I'm sorry. Am I back?
Yeah, you're good now.
For me, anthropology and the training that you get from it and what it all basically comes down to is taking other forms of knowledge seriously. So taking non-hegemonic forms of knowledge seriously, and taking you know, other actors in the field who you would not normally talk to seriously. And in my case, it comes back to having that knowledge inform the work that I do. So I've always been a very engaged anthropologist, a very, I guess, activist inclined anthropologist. And that's how I came to the field. And so now I've found this discipline that really fits. So yeah, I'm happy to expand on that.
Thank you very much. Thank you both for really giving introductory remarks that are just the tip of the iceberg, and we are really looking at conversation. And to our audience, you can see from our panelists what they talk about. The aspect of humanity really comes on board, really very important. And I can say, once you think about human beings, what people do, how do they live, their society, their health, their biology, and everything. I mean, anthropology is all about human beings. And if you question yourself now, you will realize that today, all of us are actually anthropologists at heart, because we question about humanity, we question about the people we live in society with, and these are very important aspects that we try to explore in society. And just to start our conversation, Aneel, you mentioned the issue of inequality, or something that really drew you to the attention of really exploring the field of anthropology. And you've done extensive work in India trying to explore issues of inequalities, structural violence, and vulnerabilities. Maybe can you tell us more about your work in India and how it relates to mental health?
Sure. So as I mentioned, we started off with a very simple maternal health center, and the goal was very simple. So I run a nonprofit called the Mata J Core Maternal and Child Health Center, and about 10 years ago we started just a clinic to serve very basic prenatal care to vulnerable women in this rural area, women who have poor access to care. And as we were doing that work and we learned more about social vulnerabilities, structural vulnerabilities, that led us naturally to think more about mental health, because, you know, there are social economic barriers to accessing just biomedical care, safe childbirth and those kinds of things. But there are also other factors that impact the woman internally, psychologically, that affect care as well. And so what we wanted to do is expand our work to include mental health provision. And we started using the lay counselor model, the stepped care model that Zul alluded to earlier. And along with this, we thought that this would be a very good way to understand society better. And so we embedded, you know, very ethnographic participant observation work in that.
Great. Thank you very much, Aneel, for really telling us what you've been doing, or you've done rather, in the past in India, and we'll continue engaging further in relation to your work. And as anthropologists, we not only study the present, but we are really informed by the past, because We believe that the past informs us better to understand the present and even predict what is going to happen in the future. And Andy, you've done a lot of work in relation to intergenerational trauma in South Africa from the apartheid period to the present time. As a biological anthropologist, how have you been able to explore intergenerational trauma in South Africa?
Yeah, thanks for that question, Edna. I think you're exactly right that we're really able to understand both the past and the present to make sense about what's going to happen in the future. And this is exactly what brought me to the work that I'm doing now. Part of the inspiration also just came from my own lived experience as a child of Korean immigrants and a descendant of grandparents of mine who survived the Korean War and Japanese colonization. And given the dire situation that's been happening, many contexts across the world that have been facing war, societal transformation, genocide, I've always been really interested in understanding what are these intergenerational legacies or long-term legacies of these sort of mass atrocities, and how do they play out in everyday social contexts, but also affect health, and what can we do to try to undo these effects of colonialism, of war, that in order to create healthy and thriving communities. And for me, this question was particularly relevant for the South African context, which of course only recently transitioned from the apartheid regime into what's considered to be a free and democratic South Africa. Of course, people would contest that very heavily even to today. And for me, I was particularly interested in understanding these sort of invisible, unknown mechanisms of health inequality and social inequality that operated as a result of intergenerational trauma. So I work closely with a longitudinal birth cohort study called Birth to 30. And Birth to 30 started in 1990, which by recruiting approximately 3,000 pregnant women in a specific catchment area outside Chris Hani Academic Baragwanath Hospital, which is a large public hospital outside of Johannesburg in a large township called Soweto. And the study followed up on these women who gave birth to their children, as well as their children on an annual basis, even into the next generation, so spanning 3 different generations, in order to understand what these life course mechanisms were, life course consequences of the dissolution of apartheid, which is quite violent in the context of Soweto. So my particular research looks at 3 things. The first is a basic science question to understand these mechanisms of intergenerational stress transmission through biological mechanisms, specifically looking at the dysregulation of stress mechanisms such as the hypothalamic pituitary adrenal axis, which produces stress hormones like cortisol, immune function, and other molecular and genetic processes that could potentially underlie the process of intergenerational trauma. Second, I also look at these developmental processes and life course mechanisms to understand how and why this occurs within human biology and health. And then the third, again, going back to the particular discussion around the holism of anthropology that really provides us as scholars to understand the social and political and economic implications of this work. So of course, there's been a very fraught history of science and studying human biology in South Africa because of the past eugenic histories of the country. So how does this type of work and this type of research operate in the context where questions of transitional and restorative justice are still unfolding in a country that's continuing to reckon with its past? Of course, these have multiple implications, trying to understand the production of mental health inequities, the psychological underpinnings of social problems, and just the mental health burden generally. In South Africa, there's a 92% treatment gap. So 92% of people who need mental health treatment aren't actually getting it. So we take this multifaceted approach to try to understand and really, I guess, embrace the complexity of these life course and intergenerational mechanisms of inequality that affect mental health, which have very dire consequences on people's daily life and into the future.
Thank you very much, Andy, for really giving us a snapshot of your work, and of course trying to relate with the different, an interplay of the economic, social, and even the appetite. We know the history and the politics that were involved and the consequence this had to mental health. And more often you find when patients present at the clinics, really the clinician or the healthcare worker might not really have time to really go deeper to understand all these issues. And this is what anthropologists do, try to understand all these factors and how they shape mental health, not just for today, but even for the generations to come. And I like your story when you started by saying how your history really prompted you to try and study this intergenerational trauma, because what your parents and grandparents experienced before might have influenced your mental state at present, and you also wanted to explore how it can even affect your future generations. Really very important insights. And other than the intergenerational trauma, we know there's a lot of community empowerment. Dr. Amuyunzu, you've been working on issues. Dr. Amuyunzu is an applied anthropologist, a lot of work on community empowerment. And in the Q&A sections, I've been able to just pick a few questions that relate to your work that I might want you to talk about, especially what strategies do you use to engage with people at the community in terms of enhancing their physical and mental health? Over to you, Dr. Amuyunzu.
Thank you. First, I want to reflect on how our communities really address mental health. My socialization into mental illness was people locked up, tied up, isolated, stigmatized. And over time, through an anthropological lens, you realize that when communities don't know how to deal or resolve an issue, they hide it, they run away from it, or they ostracize it. And growing up, we had only one definition of mental illness. It was you are mad. But with time, you begin to realize the limitation in appreciating matters to do with depression, for instance. We did a study in the late 80s, where we were looking at depression in mother tongue. And those who are here who are from Kenya, just reflect on it. It's either deep sadness or deep, you are really deeply sad. There's no direct translation to that term. And over time, and increasingly, people are beginning to recognize and appreciate that mental illness is a key issue, but this has taken time. On our work on non-communicable diseases, we realized that when you have a chronic illness, your mental health is affected, not only your mental health, but of the people you live with, of the people you work with, of the people who are taking care of you. So when you look at the various conditions we've worked on, mental health, gender-based violence, and all these issues, including poverty, somebody has talked about poverty being a trigger to mental illness. It is important for us to recognize that from an anthropological perspective, you need to look around what's happening to this individual who is exhibiting symptoms or who has been diagnosed to have mental illness. There's a lot going on around the person. So when they sit in front of you, you do not focus only on that condition. You want to look at what's happening around that person. In addition to that, when you're looking at the care for people with mental illness, you really need to consider the belief system, the social approach to this, and the various etiological beliefs in that community. Because if you believe mental illness is caused by witchcraft, then we really do need to look around, where are they getting help from? What is motivating them to get that kind of help? So through the work we do, we basically encourage communities to define where the issues are, and also to define what solutions they have for that problem. My feeling and my conviction has been that communities have the answers. We need to facilitate them, to empower, and they'll have solutions to those problems. So long as they have the information, they have the awareness, they are better able to provide care for the people who among them have issues, have problems, have conditions that can lead to mental illness. Over to you. Thank you.
Thank you very much. A really interesting insight. Just to continue from where Dr. Nyamongo has stopped, we know that as anthropologists, we look at mental illness as being shaped by different factors. We talk about culture, we talk about biology, psychological factors, and so on and so forth. But Aneel, we also know that as anthropologists, we know culture plays a very critical role in shaping, in defining abnormalities or normalities, in actually drawing scripts on who is sick and who is not sick. As Dr. Nyamongo talked about, when do people feel like they are sick? And this really touches much on mental illnesses compared to other physical illnesses. Aneel, do you want to expound on the issue of culture and illnesses a bit more?
Sure. It's a contested space, so I think a couple of generations ago, and there's a line that even continues to today, there was a thought that mental illness was very, very culturally specific, even to the point where, say, things like depression might not exist in India, for example. I'm just reading a book where that was questioned from the 70s, because people think of depression in different ways. And a lot of that thought comes from an anti-psychiatry movement where you define where mental illness is sort of thought of as something that is constructed in the West and doesn't apply elsewhere. The way that I see this has evolved, and I'd love to hear what the others say, is that depression is a universal experience, right? And I think that anthropology has had a lot to do with understanding and contextualizing this. At the same time, context is important, which is what both Andrew and Mary mentioned. So while depression is universal, there are specific things like a colonial past, or access to healthcare, or poverty, or other things that are specific to context that really impact how mental illness shows in a certain individual in a certain place. I can give you, something that I'm working on in my context is the nature of patriarchy for women in my area. So it's a specific, it probably shares features with Pakistan and other South Asian or North Indian regions, but there's this particular type of patriarchy, and features of this will figure everywhere, but where women are really, really responsible for a lot of things, for the integrity of the household, for economic things, for reproducing, for having children, having male children. And all of this can really, really specifically in a cultural context affect mental illness. Anthropologists have had a big hand in understanding these dynamics.
Thank you very much. Thank you for expounding further on the issue of culture. And so presently we know that mental health or mental illnesses or disorders are really very getting more dire to adolescents and young people. It's something that is more common now amongst the younger generation compared to some years back. And we know that in the near future, 1 in 5 people who are young people, adolescents or young people, will be an African youth. So Andy, would you like to talk about what is the prevalence of mental illnesses amongst the youth, and what does the statistics tell us or try to highlight to us in terms of the future of the youth in Africa?
Sorry about that. Yes, thank you for that question. You'd assume after many years of Zoom, I get this right. Yeah, no, we're actually blessed with recent statistics on mental health in the sub-Saharan context, which I think someone mentioned earlier, something that is really an impediment to mental health equity in the continent, the lack of research on mental health, and also funding and infrastructure for mental health in the continent. And these recent statistics have shown that in sub-Saharan Africa, 1 in 7 adolescents face significant mental difficulties, and approximately 1 in 10 are estimated to experience a specific psychiatric disorder. Of course, this is based on categories of psychiatric disease that are defined by the DSM-4 or 5. So there may be other types of mental distress that aren't being recognized by these sort of biomedical systems. And I think this is also an important thing that anthropology contributes, really understanding culturally and locally specific ways of experiencing something that many define as a mental illness or mental distress. Mental illnesses are actually also among the leading causes of disease burden among children and adolescents in sub-Saharan Africa. And I think this is a really important point to emphasize that Mary also highlighted previously, where mental health, physical health, and other types of social well-being are intricately tied together and important to consider. In South Africa, for example, there's a large body of research that talks about how high levels of mental distress are impeding people from attending hospital, from adhering to medication, and also having its own independent effects on well-being. And this is particularly concerning for specific contexts where children face multiple socioeconomic, political, and health adversities, which of course follow legacies of years and decades of colonialism and failed structural adjustment programs that have occurred not only in the African continent, but also different contexts across the world. And so of course these legacies include contexts of high poverty, limited opportunities for schooling, and health risks like malnutrition, trauma, and limited education. So these obviously aren't just operating as a result of independent suffering, but deeply historically and culturally contextualized as a result of large waves of global violence that have occurred within the African continent and elsewhere. I think on the flip side, what's really important to recognize when having conversation on mental health is not just talking about suffering and talking about distress, but also talking about natural forms of coping, resilience, and healing that people have been undergoing and experiencing throughout time. So these are indigenous and naturally occurring processes of healing and healthcare seeking. So these could be things like spirituality, family and community support, and different creative interventions that are culturally specific. I'm sure Aneel can speak more to this, but I think it's really important for these interventions and the work of applied anthropology to, and public health largely, to optimize these initiatives that really garner support, that are already community grounded and based on deep historical knowledge of local contexts and problems. So the last point I'll make is that the most recent WHO mental health atlas found that of the 47 WHO member states, only 16 countries still lacked a standalone mental health policies. And this is really concerning given the high prevalence of both psychiatric disease, but also psychological morbidity, which is typically a lot higher than disease prevalence. So even the lack of policy enactment in these contexts just really speaks to the fact that mental illness is still considered to be, I guess, like a forgotten topic, both in health and society.
Mm-hmm. Mm-hmm. Absolutely. Thank you very much for pointing out this critical point. And given the issues that youths are experiencing, and of course, coupled with mental illnesses or disorders, youths are also experiencing poverty. You mentioned inequality, unemployment, a lot of things, including HIV, AIDS, and other epidemics. Dr. Nyamongo, Andy has just alluded to the fact that, care or even policies for mental health are not really very, they have not been really addressed. And what are anthropologists doing to address some of these challenges that youth are experiencing? Over to you, Dr. Nyamongo.
Just to draw from what the speaker has finished with is the fact that having a policy base or having a law or a regulation or a legal system in place really helps actors in moving towards redressing some of these problems. So policies, the legal systems are critical. And just to mention that in Kenya, we've seen some movement towards ensuring there's a platform, a framework upon which some of these issues are addressed. I know Dr. Professor Lukoya is here, is heading part of this work in this country. But my biggest challenge has been the limited use of anthropologists in some of these discussions. If you remember when COVID was acknowledged as a problem in this country in March, task forces were put together, but really there was no anthropologists on those task forces. We asked to be included, it didn't happen, so we became activists. We basically started speaking about the way they were treating the patients, the way they were treating the burial. So we found different ways in which our voices would be heard, because the system did not recognize the importance of anthropologists at the table. He's talked about a very key issue on the youth. Every week, every other week, there's homicide, there's suicide. There's a young man who has traveled all the way to Mombasa to check on his girlfriend. He ends up killing her. There's just something going on. Economic difficulties. This particular period has been very difficult for a lot of young people. So you see a lot of that translating into depression, into mental illness. And unless there is a system in place that identifies these triggers and ensures that those young people who are exhibiting signs and symptoms of mental illness are taken care of, we end up losing young people when we can actually protect them and save them from these outcomes. And therefore, as we begin to look at this issue, is to encourage people who are sitting here who are not anthropologists, who are in positions of decision-making or positions of power, to really look at who is at the table, that we each have a role to play. We can contribute ideas, we can contribute strategies, we can contribute other resources that can help us to comprehensively address mental health and mental illness in this country and beyond. So it is very, very important for measures to be put in place where you look around and say, who are we missing? Who is not at this table? What I've realized in this country, and that came up in the first quiz you had, a lot of people don't understand anthropology, and therefore decision makers don't understand anthropology, and we will not be the first discipline for them to say, oh, we are missing an anthropologist. They may say we need a psychiatrist, they may say we need a social worker, but it's very rare that they think anthropology is important. They need to be at the table because we look at what makes us human, and therefore it's very critical for us to be involved. Over to you.
Thank you very much, Mary. Thank you for really wrapping it up very well. And it's really, it's so sad that we are talking about, improving mental health when we still have all these gaps unaddressed. And when people like anthropologists are not even brought onto the table. And you remember, the world recently commemorated the World Mental Health. And the theme for this mental health was mental health in an equal world. How are we going to improve mental health when the inequalities still exist, when we still have gaps? So those are some of the challenges that are really existing, and until those gaps are addressed, engaging with different people to address those gaps, then that's when then we change the narrative and say, let's respond to these issues, let's improve or enhance mental health. We can't enhance mental health while really, like closing the eye or trying to look at the other issues as if they are not very, very important. And Andy, I know you've done a lot of work recently on COVID-19 in South Africa. Would you like to talk about these inequalities in relation to COVID-19 for just a few minutes, please?
Yeah, sure. So COVID-19 obviously is affected the entire world, and I think what we've seen through a lot of recent social analysis is that COVID has not only introduced new stressors and new traumatic events to different societies, but have, in addition to that, exacerbated existing inequalities. In nationally representative studies of COVID in South Africa, we've seen greater levels of joblessness, food insecurity, and potentially greater levels of violence that have occurred as a result of these specific contexts of deprivation. So these inequalities have continued to exist, and thankfully there's been a large body of research, especially from medical anthropology, that have aimed to understand these determinants of inequalities, as different lived experiences and meanings of inequality and these implications on health. I wanted to highlight, I guess, two different types of contributions that anthropologists have really been making in the research on COVID-19 that Mary had also alluded to, which is, I guess first to recognize that anthropology is an extremely broad field and has made contributions across various scales, from studying the immune response due to COVID-19 infection to the global politics of vaccine distribution. The two areas of work that I've been really following that have been really promising and really being led by anthropologists are first really understanding these holistic complexities of how different spheres of environment, life, and health are intertwined and manifest to not only affect social suffering as a result of COVID, but also people's reactions to the pandemic. So these are including understandings of health risks, disease perceptions, government regulations, and existing social inequalities. Obviously, all of these things are relevant for the COVID-19 context, but anthropologists, with their holistic perspective, really are trained to really hold these complexities all at once in understanding how they're meshed together to understand how people make sense about their situations and behaviors. So obviously anthropologists are really key in understanding how disease pandemics are affecting people's lives and potentially continue to affect people down the line. The second is around, of course, the mental health impacts of COVID, which really have been widespread and differentially detrimental, especially among those who have already experienced some form of psychiatric disease or mental distress. Anthropologists have really been at the forefront of trying to understand these sources of mental illness risk, effective coping mechanisms, as well as the mental health needs. So recently, we've been leading, actually both Dr. Bosire and I have been collaborating on a number of different publications that have been investigating the COVID-19 context in Soweto and Johannesburg. We've identified a number of different socioeconomic, religious and political implications of COVID-19, but also looking at the long-term mental health consequences of COVID as a result of pre-existing inequalities, but also compounding with new adversities faced by the pandemic.
Thank you very much. I can see we are running out of time, but just to try and sum it up, Aneel, please, will you talk something about, I mean, as we are aiming, or as we work as anthropologists, we work with the communities and policymakers, but there's this group that is largely unaddressed, and these are clinicians or healthcare providers. What we say as anthropologists is that they need to be trained to really recognize some of these social or macroeconomic issues that shape mental health. So what do you think should be done to the clinicians in terms of enhancing their cultural competence skills?
It's a conversation that needs to be had, and I will go back to Professor Nyamongo's response, which actually really fired me up. It's about who's at the table and recognizing power imbalances, right? And so I'll go back to the first response I gave about what anthropology means to me, and it's really about recognizing different forms of knowledge and other actors in the field who are normally invisible, right? And through there's a question in the Q&A about specific techniques. I think Maria Iqbal has asked, what are specific techniques that anthropologists can use? And we use participant observation, we use ethnography, at least on the social and cultural side. And if we can embed this with health interventions, we can get to some of this knowledge. We also have theoretical insights, and then the important ones are structural, so structural thinking. And if we can get clinicians to think in these terms, what are some of the structural racism that goes on that brings someone to your clinic in the first place? They don't have to be deep ethnographers or theoreticians, but if they're not asking structural questions, they're missing a big part of caregiving, which is their job. The third thing I think that is really important is just and which attracted me to anthropology, and that I think Professor Nyamongo just showed, and also Andy shows, is a passion for this kind of understanding and insight, right? And doing the work and being an advocate, and advocating for people. If we can have the tools through ethnography and participant observation and combining those with implementation science, if we can see people who are invisible and we can hear their voices, it then becomes incumbent upon us to bring those voices to the table, and ideally bring those people to the table, and have clinicians understand what goes on, not just with the patient and their biomedical symptoms, but what goes on beyond, which is the structural and the racism and the colonial history, and to have that inform their practice. So hopefully that answers the question.
Thank you very much. Yeah, as we move on, I've seen some quotes or some chats in the Q&A. I've actually moved to the Q&A, and some of the chats are really commending the work, but also a need for more understanding on resilience. And Andy alluded to the aspect of resilience. And as anthropologists, we know that still culture and society shape how people are able to, bounce back to life amidst the adversities that they are going through. So we've seen people or communities that we've worked with, not everybody really goes to an extent of getting down. Some people are actually able to survive within those, the different difficulties that they go through. But we find that resilience is still shaped by culture and also society, and also the resources that people have. And this doesn't have to be monetary terms. It has to be also with social issues, social networks, social relations, and beliefs, and also religion and other aspects that people hold dear to when they are confronting issues. And someone from the audience has actually said, it's not easy, Dr. Nyamongo, I'm directing this to you, it's not easy to bring everybody to the table. When we talked about having anthropologists in the table, it's not easy to bring everybody on the table. So Dr. Nyamongo, the question that I will link to this is, how then do we change the narrative to interdisciplinary or multidisciplinary kind of approach when you are talking about mental health?
I think this has happened already. We begin to see a lot of spaces opening for anthropologists and other social scientists. I remember a doctor friend asking me, how come this TB patient comes here, I give him medicine and he doesn't take it? I asked him to have a discussion with the patient. The next time I met him, he says, I understand he lives in a difficult environment. He doesn't have supportive family. He doesn't have food. So basically, he was talking to somebody whose social environment wasn't supportive of the medical intervention. So increasingly, when we started in this space in the 80s, it was difficult to work with our medical colleagues, but currently we work hand in hand. It was also even then difficult to publish an ethnographic paper or a qualitative paper. We increasingly are using mixed methodology. We are combining both quantitative and qualitative tools for data collection. And so I think the field has opened up, and there is recognition that all disciplines are important and there's a role we can play, especially in non-communicable diseases, in neglected tropical diseases, and in mental health. So I just want to encourage also as anthropologists, let's also put ourselves out there. Let's say we are here, talk to us. We don't wait to be looked for. Let's look for our colleagues. Let's insist we have a role to play. And if we do that, the appreciation will increase, especially programmatically. When you implement a project, there's a role for each one of us to play. At the community level, we are better able to maybe connect, but we still need the clinicians to do their bit. We need the psychiatrists to do their work. We need the nurses and the nutritionists to be involved. And therefore, this mutual understanding is growing, and we hope that we continue to grow in all spheres. Thank you.
Thank you very much, Mary. And I've seen some chats on the chat box. Maybe next time we should invite John Farmer. I guess the person who wrote is Paul Farmer. Yes, thank you. Yeah, Paul Farmer is a really well-renowned anthropologist, and he's done a lot of work on inequalities. In Sierra Leone, he was really a key figure when we talk about Ebola. And in Rwanda and other African societies, including Malawi, he has developed what we call partners in health. trying to address issues of HIV, but really from the point of structural violence and structural vulnerabilities. And also another one is called Arthur Clayman. You might want to read more about Arthur Clayman. Arthur Clayman is a physician, a psychiatric, and a psychiatric anthropologist who's really done a lot of work. And some of the books we read and we continue reading are from Arthur Clayman. There's a comment from one Professor Simiyu Wandiba. Professor Simiyu Wandiba is a retired professor from the University of Nairobi, and he taught me many years back. And he's asking a question: how come people who are mentally ill do not see themselves as being sick? His question is posed to my panelists. How come people who are mentally ill do not see themselves as being sick? Mary, do you want to jump into that?
I think there was an answer to that in terms of how do you define normal and what is the difference between normal and abnormal, and what are the social cultural parameters. Maybe somebody we consider mentally ill here is not mentally ill in another context. So the issue of normalcy really depends on where you are, how it's defined. But I'm not so sure, Daktari, Professor, that I would be able to describe how these people don't see they are mentally ill. Maybe we leave that to a psychiatrist who may be here. Professor Lukoye, if you're still here, can you answer for us that question? You deal with these people on a daily basis also. We really do need to hear from their perspective in terms of what defines their illness. Thank you.
Professor Lukoye?
Edna, I think Professor Lukoye will need to respond in the chat unless we can quickly give him access to participate by voice. But why don't we ask him to comment in the chat?
Okay. Yeah. So yeah, he can comment on the chat, and I will ask more questions. Yes, Professor Zul.
Yeah. So maybe I can step in and say that part of the problem is that very often people who experience mental ill health are not quite familiar about the symptoms of mental illness. They don't know that those symptoms belong to a cluster that we define as depression or anxiety disorders, things like that. That's one of the reasons. The other one, of course, is self-denial. And you might think something else is going on and you don't want to admit the fact that you might have mental illness. And finally, I think the issues of stigma, self-stigma, as well as stigma from our friends and family very often preclude you from really coming to terms with the fact that you have mental ill health. So there are many factors and more that contribute to this line of thinking and not admitting to the fact that you might be suffering from mental illness.
Aneel, I can see your hand.
Yeah, I'll just add that, it's can go the other way. It could be the definition of the term illness and how we define mental illness. And we all know that there are manuals now, like the DSM, that define certain mental illnesses. And sometimes people don't fit into those categories. So they're just not, the categories don't exist, or they don't think it exists for what they're going through. But I guarantee if somebody's suffering from what we would call mental illness, if you ask them, are they suffering? They will say yes, right? They may not be able to define it as I'm sick based on what's out there, but they're definitely suffering. And this is another anthropological perspective that we can help uncover, So there are changes in understanding with how that DSM manual has evolved over the years. For example, homosexuality was considered a mental illness not too long ago, and then it was defined out, right? So yeah, sometimes it's just the definitions that are out there and being able to fit into those categories, and then consequently being able to get.
Yes, absolutely. And remember, it's all about how the culture shaped how they define these illnesses. It might be an illness in one culture, it might not be an illness in another culture. So culture still plays a critical role to this. One more question from our panel, from our audience. is how do we tailor interventions to match the local context? Like, how do we tailor interventions to match global approaches? Because we have like global frameworks, and that is one thing that we could not discuss because of time. We know that we are informed, like we have a WHO framework, or you know, for example, a resilience scale, a scale that is used to assess these diseases. How do we ensure that we tailor it to match local context? Mary or Andy, anyone can jump into that?
Let me just quickly look at what WHO does in terms of frameworks and guidelines. We, as anthropologists or as social scientists, we consider those important, but we advocate for those to be contextualized at the local level. So basically, if we get a scale from a different continent, a different country, we advocate for that to be channeled through a cultural context to ensure that it's relevant to the social cultural context of where it's being implemented. So those are important because we live in a global world. We are interconnected in several ways. We cannot run away from that, but we should not just wholesomely implement those guidance, those instruments. We really need to contextualize them within the area where we are implementing the work. Thank you.
Thank you very much. And when we introduced anthropology and even defined what anthropology is, what we forgot to mention to our audience is the 4 subdisciplines of anthropology. So we have physical anthropology, we have cultural anthropology, we have archaeology, and we have linguistic anthropology. So today we don't have all these people here, but we have a cultural anthropologist here, we have a biological anthropologist here, we have a medical anthropologist here. So we have a different lens that we study human society and human beings. And Dr. Manasi is a senior psychologist at BMI, has asked, I would like to know if the speakers can highlight the difference between biological, psychiatric, psychology, and cultural anthropology, and what are the current challenges in each of these fields. Anyone, Andy?
I think this could be its own webinar, but I'll say first that you know, typically psychological and psychiatric anthropology have a lot of overlap. Psychiatric anthropology tends to collaborate a lot with physician scientists or psychiatrists themselves to understand, you know, how culture, politics, and history shape mental health and obviously psychiatric experience and disease, and oftentimes clinical settings, but also non-clinical settings. Psychological anthropologists, I would say, do very similar types of work, but explore broader types of concepts related to the mind, psyche, different types of psychological experience, with lots of overlap with medical and cultural anthropology. Biological anthropology, as I said recently, is a study of variation in human biology and health outcomes. And in terms of current problems that I think biological anthropology is facing right now is really a strong, the need for critical perspectives when it comes to understanding social inequality, the role of colonialism, and power in understanding biological and health outcomes that I think even the world of public health is still struggling, and medicine is still really struggling to grapple with now, that medical and cultural anthropologists have long been studying for a while. And medical anthropology, the study of health and healing from different cultural, political, and historical perspectives. I'm sure others can expand on this as well, but I think one important thing to note is that so many of these subdisciplines are really intertwined with one another, and the practice is done that way for a reason, in that anthropologists don't see things specifically from you know, schematic focuses or in different silos, but that, you know, human life is really complex and needs to be understood in its complexity.
Interesting. And we have a comment here from Adelaide. Adelaide said, for many years, anthropology has been misconstrued as a discipline that enhanced colonialism and perpetuated racism. So this is something that people are wondering, are we not still perpetuating racism? Remember, when anthropology, you know, it's something that people are wondering here. So I don't know if there's anyone who wants to comment on that.
Yes, I will comment on this one, because as the initial students of anthropology in this country, there was a lot of misunderstanding of what we were studying. Oh, are you studying bones, anthropods? So there was really very little information about what we were looking at. However, what we study, and I think the examples given here for applied anthropology is rendering understanding of the people we are dealing with. It doesn't matter whether you're looking at poverty, health, social issues, economic issues, there's always a role for anthropology, production system, agriculture, nutrition. And therefore, we really are dealing with questions that or issues that people are experiencing currently. So you could look at things historically, but in terms of applied anthropology, we are asking questions that really provide support towards interventions geared at improving people's lives. So in health, we are looking at how do we treat, what issues are people dealing with. In development, we are looking at the social impacts of development on the human beings doing no harm. So from an applied anthropological perspective, we are addressing needs, real needs, and providing a people lens to addressing those needs. So increasingly, I think we need to disabuse people from this notion that we are perpetuating colonialism, we are looking at backward science. There's one of our leaders who even said we should scrap anthropology, which is really unfortunate, given the fact that we are providing real support, real insights to real problems. Back to you.
Mm-hmm. Thank you very much. I'm just trying to understand someone's question here. How could someone address the issue of the role of mental health models grounded in local interpretation of religion and how these and people upholding them may be, okay, I think the question is trying okay, the person is trying to ask how we can adapt the mental health model to try and fit the local context. And just a quick response to this, I know Andy has done a lot of work. Actually, one of the scales they've tried to adapt is called the resilient scales for adults. They took one of the psychiatrists called Freiburg. He developed a scale in 2005. And what Andy and the team did is that they tried to use this scale to understand resilience in South Africa amongst adults. And what they found is that this scale was not really fitting the Sowetans that they were studying, because some of the questions, first of all, were not even comprehensible to the people who are using it. Even amongst those who could speak English, they could not understand what the questions meant. But again, the scale was not able to, to really take care of the local context that people experienced every day. So what they did was to now literally change most of the questions, or to translate them to fit the local context. So Andy, would you like to expand on this? Did you guys expand on that scale, or compress it? But I know there's that paper on, yeah, you can talk about it, sorry.
Yeah, I think Dr. Bosire gave a very nice summary of the study already, and I don't have anything else to add. But I could say that, I think this question is really important because I think it really highlights the fact that there are various meaning-making systems that we as humans involve when trying to understand just our lived experience, let alone mental health. There's so many different aspects of mental health, as Pasul has mentioned, that are really a cluster of different symptoms, but also, deeply intertwined with, socioeconomic context, your gender, religion, and other aspects. And it's really important to take these understandings into consideration, especially when we try to assess or measure things like mental ill health, mental suffering, healing. In an attempt to address this question, that we have try to utilize emically derived models or ground up models of understanding how mental health and stress are experienced in local contexts from people's own lived experiences, doing rich qualitative research as well as ethnographic research in order to develop a culturally grounded scale to assess mental health. And in many instances, these types of emically derived measures, locally derived measures, tend to do a better job of assessing and measuring experiences like psychosocial stress or mental health, and currently being adapted so that we're basically being accurate and precise with our measurement of these experiences. Religion playing a very large role into this. There's been a lot of work on this in the South African context, in Haiti, I'm sure in Kenya. I'm sure Edna can expand on some of her work that she did with idioms of distress. But lots of really interesting work that's really addressing this question centrally.
Interesting. Thank you very much. I wish to thank the panelists for really trying to showcase the different contributions they make to mental health. I'm sure we still have a lot of questions, but because of time, we are already past the hour, and we really thank our audience for really staying in put and continue engaging with us. I think we can have a follow-up conversation from this and continue answering some of the issues, or even creating clarifications on what anthropology does. You can drop a message in the chat on what you'd like us to follow up on. And thank you, Andy, thank you, Mary, thank you, Aneel, for really wrapping up everything for us. We've been able to understand the role of culture and also politics and the economy and how they shape mental health, but also how anthropologists are really contributing in terms of policy and practice. And Dr. Nyamongo has been able to really showcase this. So what we've done today is just to showcase the different aspects that anthropologists are impacting at the community in policy. This is not exhaustive. As I mentioned, we'll continue engaging and inviting you for other webinars. Please sign in for other webinars. So at this, I'll just end this conversation and hand over to Zul. Zul, over to you.
Thank you very much. Fine job. It was quite exciting. A lot of interesting topics that came up that we didn't have time to kind of fully address, like issues about exactly what's the interface with religion and how does that factor in, and how do we transition from the medical model to the biopsychosocial model. Those are kind of big questions that I think we probably should be addressing going down the road. There seems to be a fair bit of interest, but certainly quite exciting to see so much engagement in this subject of how anthropology can begin to tap into the voices, the unheard voices of those that are suffering in silence. And I think to bring that to our fore so that our interventions are much more effective. So I think, thank you very much for the panelists for very enlightening discussion and viewpoints, and putting a lot of information and your energies into addressing this important topic. Thank you, Diana, for moderating the webinar, and Edna for a superb job in terms of handling the panel discussions. So, and the panelists, of course, for participation. And last but not least, the audience. It was great having so many of you from so many different places, and hopefully this will encourage us to kind of continue this line of conversations going forward. But I hope you at least now understand why anthropology is so important to mental ill health. So thank you one and all. Bye.
Thank you, Zul. Thank you, Edna. I'll just close up the webinar here with the reminder to finish the poll if you haven't already done so. And please engage with us at the Brain and Mind Institute. We are a friendly bunch, a wonderful bunch, a concentration of new talent in an important part of the world where these issues need more attention. So we really want to underscore the invitation for you to engage with us, be in touch. This webinar is a point in time. Obviously, you can see we're keen on these issues, and we know you are too. So join us in the effort, and thank you very much. The webinar is concluded.